Once again, these are not guidelines, these are just ways on that one might approach findings in the primary care setting. I would like to talk about proteinuria, which is when proteins are spilled in the urine. So proteins are not supposed to be in the urine, they're supposed to be in the blood because that's what keeps the fluid inside the blood vessels. So whenever you see proteins in the urine, you want to find out why is that happening. Could be because the kidneys are getting damaged, and there are many causes of kidney damage. And the major ones in primary care that we could see are diabetes, high blood pressure, lupus can also damage the kidneys, rheumatoid arthritis can damage the kidneys, medications, renal cysts also can damage the kidneys, HIV, gout, hepatitis C, hepatitis B, even street drugs. So there's a lot of reasons why proteins might be spilling in the urine, which would signal that the kidneys are being damaged. The most frequent ones in primary care would be diabetes and hypertension. Now, how we might go to approaching this situation is you want to repeat UA and might want to do a culture sensitivity just to rule out any infection, and then to rule out any transient, not hematuria, but is proteinuria, just to see if it resolved. If it was just something temporary, you might want to wait maybe a week or a few days. But let's say you repeat it again and it still comes back positive, and there is no symptoms of UTI, no symptoms of any fluid retention, then you repeat it by the third time. And if it still comes back positive again, maybe you want to wait after the second time a week again or 2 weeks. You repeat it by the third time, it still comes back positive, then you want to place them, if you can, on an ACE inhibitor or ARB, just to improve, to provide kidney protection. Also, you might want to refer them to the nephrologist just to see if they can help figure out why is it that the patient is spilling proteins in the urine. You might want to also do a renal ultrasound, and the reason you want to do it is because you want to rule out any renal cyst. It also might give you information about renal stones or arterial renal stenosis, but one issue that it is found many times is that the patient might have renal cysts. So if there is renal cyst or even renal stone, you want to make sure that the patient sees a urologist. You do not want to be the last person finding out renal cyst and the patient not being seen by the urologist. If there's no apparent cause and still being proteins being spilled in the urine, you want to make sure you send the patient to a nephrologist if you couldn't find the cause. But if the patient had renal cyst, you want to send them to the urologist. Now, if the patient is symptomatic, you want them to report to you as soon as possible, because you want to make sure that there is no nephrotic syndrome that is developing and the patient not being aware of it, such as ankle edema, periorbital edema, lethargy, anorexia. The edema, of course, occurs because as you're losing protein, the osmotic pressures decrease because there's not enough protein to hold the fluid in place, and then there is fluid going into other spaces in the body. Now, there are other tests that could be done, but I typically would refer them to the urologist to look into that. Now, there are many other reasons that can cause kidney damage, leading to proteins being spilled in the urine. And if you have the chance and you can order it, you should order if you can. And I'll just go over some of them. But of course, diabetes is one of the main ones in primary care. Also, when there is prostate issues, that can also cause proteinuria. So you're looking for anything that could be causing pressure in the kidneys or could be causing damage in the kidneys, but also anything that could be attacking the kidneys from different angles, such as cancers or autoimmune conditions. They can also cause damage to the kidneys because of proteins being produced that go to the kidneys and cause damage. And there are labs that you can do to see if they can help you try to find out what could be happening. When you do a comprehensive metabolic, you're just checking for diabetes, you're checking for electrolytes, make sure they're okay. You're looking at the creatinine also to see if there's an increase in creatinine, which would signal something damaging the kidneys. When you do a CBC with diff, you're ruling out anemia, which could happen when their kidneys being damaged, but you're also looking for abnormalities in the blood cells, like if the lymphocytes go up or go down, if the white blood cells go up or go down. You're looking for cancer in the blood, which would create proteins that damage the kidneys, and because of that, you would see protein being spilled into the urine. Autoimmune conditions as rheumatoid arthritis, you would check by doing the rheumatoid factor, CCP antibody. Those rule out rheumatoid arthritis. Sedimentation rate and CRP, these are markers of inflammations, but also sedimentation rates can increase when there is cancer in the blood, cancer in the body. ANA, that's one of the preliminary tests to look for lupus, but it also goes up with other conditions such as thyroid disorder, autoimmune thyroid disease. But ANA can also go up with lupus. Smith antibody, dsDNA antibody, that happens with lupus. That comes back positive with lupus in many cases. And lupus, of course, can damage the kidneys. Hepatitis B, surface antigen to rule out hepatitis B. Viral infection, hepatitis C antibody to rule out hepatitis C exposure or infection. HIV also can damage the kidneys. Uric acid, as gout, can damage the kidneys also. SPEP, or serum protein electrophoresis, that's a test that rules out for multiple myeloma or monoclonal glomerulopathy of unknown significance that can produce proteins that can damage the kidney. And also ANCA-P and ANCA-C, those are tests to rule out vasculitis, which when it occurs in the kidneys, you could have spillage of proteins in the urine. Very well.